Thank you very much, and it's a nice small audiences are often good. Now it's a little it's a topic which is not discussed so often, but actually it's a common medical problem. So what we have is pancytopenia and ACS, and pancytopenia you will have anemia, you have leukopenia, and you have thrombocytopenia. Now, leukopenia is not very relevant to ACS unless there is neutropenic sepsis, so we will not have to actually deal a lot. The real conflict of treatment would be when you have thrombocytopenia and an ACS, because at one time you would want to use antithrombotics and you have a decrease. However, before that, we need to deal with anemia. Now, how does anemia affect acute coronary syndrome? It can contribute to the ischemia itself. That is very, very important. So you have a moderate coronary artery disease which has become unstable because the hemoglobin is 5. So that itself needs to be taken into consideration, and you might actually get away by just correcting the anemia, and your pain will disappear, and you need not do subsequent intervention or very high antiplatelet or thrombotic regime. What we now also know that apart from that, anemia, if you have in ACS, actually is one of the bad prognostic markers. And how does that? It actually causes increase in bleeding when you interfere in acute coronary syndrome. So in acute coronary syndrome, if you have even normal platelets, just the fact that there is pre-existing anemia, if you see this is the Acuity trial, it is an additional risk factor for major bleeding in acute coronary syndrome whenever you're treating it either interventionally or in medical terms. So that is important to know. And does bleeding matter? A lot of us in the earlier generation, we concentrated mainly on decreasing the thrombotic risk, decreasing the ischemia, stent it, use potent antiplatelet. But see what happens. If you do not have ischemia, if you do not have bleed, ACS has a very good prognosis in modern treatment, 3.4% complication rate. If you just have ischemia, recurrent ischemia, you have an 8.6%. But as a consequence of your treatment, if you have bleeding, which anemia is going to contribute, and thrombocytopenia is going to contribute, your mortality and complication rate is higher. So what I'm pointing out, actually bleeding, major bleeding is worse than actually ischemia. And God help you if you have both ischemia and bleeding, and this is where it lies. So anemia is important for a causative part, and that it increases the risk of an adverse outcome in anemia. Can blood transfusion help you with that? Say, suppose in a bleeding and an anemia, well, okay, I'll correct the parameters with blood transfusion and go get along with it. Unfortunately, this is again a study from the Acuity study and then a contribute, which shows that if you have blood transfusion, it really did not sort of obviate the problem. Actually, this is people without transfusion, and this is with people who receive transfusion to correct their anemia, and that was actually far worse. So then let us go into thrombocytopenia, because the most important part of the interaction in ACS management is thrombocytopenia. That is the part of pancytopenia which is very, very important to us. So let us see what happens. The treatment of ACS is basically you want to decrease the thrombotic risk, but as a consequence of that, you increase the anticoagulation, you have the bleeding risk creeping up, and this bleeding risk will become double if you have significant thrombocytopenia. And this is what we call the crossover point, where despite decreasing the ischemic risk by intensive therapy, either with interventional or medical therapy, if your bleeding risk is allowed to creep up, your overall mortality is going to be actually adversely affected. And this happened, whatever the trials, which I'm just going through them a little quicker. So if you through initial trials up to say 2000, they only concentrated on one thing: prevent recurrent ischemia, use potent antithrombotic. No one was taking care of the bleeding that it led to. Till this Acuity Synergy trial in about the early 2000, which clearly showed that if you increase your bleeding risk, even if your ischemic risk becomes lower, your total mortality will go up. And that is how the newer trials have always included in their major outcomes, major bleeding as an outcome in ACS. So that is important. So let us go through a quick case, and this is typically what will happen. This is a 79-year-old man. He has a history of coronary artery disease and a stenting. And he also has multiple myeloma. He went through stem cell implant 10 days ago and was on chemotherapy. His clopidogrel was stopped because his platelet count was low. Now he presents with this. This is, as we all know, is an acute ST elevation MI. And the angiogram shows that his LAD is totally occluded. Now, if you do not do this, if you do not salvage this LAD, multiple myeloma doesn't matter. He's going to die on you. So because this is the major artery which is good. So what do you do? So this is where I will have 4 questions, and in that question which will run through all our physicians' mind, and I'll try to answer them for you. The first is, the platelet count is low. Is it protective against acute coronary syndrome? You're doing an antithrombotic therapy, platelet count is low, intuitive thinking, then your ACS should be lower. Baseline undergoing PCI, thrombocytopenia decreases the first-year risk. Patient with severe baseline thrombocytopenia is well represented. This is clearly not the case. They have all excluded these group of patients from major trials. And dual antiplatelet therapy is not sort of prohibited in PCI. So these are the 3 questions I'm going to take you through to find out what is the evidence for this. The evidence for this: platelet play a significant role in pathogenesis, and thrombocytopenia is not protective against ACS. Please understand that. The reference is platelets are larger and more reactive. So even if your numbers are down, really doesn't matter. You'll still have ACS. In fact, I'll show you a data which shows that in ACS and thrombocytopenia, risk is slightly higher. That is because you are dealing with another disease process which is causing the thrombocytopenia, which will have an adverse prognosis. And this is, as I said, in the Horizon AM trial and Acute E trial, these were the only 2 which showed platelet count and bleeding risk, which showed clearly that you do not decrease your morbidity and mortality if you have a low platelet count. So treatment of ACS, what would we do? In moderate to severe thrombocytopenia, where the count is challenging because of concerns of the bleeding and the underlying causes. So you have 2 things to play with. You have a low platelet and also the underlying disease, which is going to be usually very, very severe. So effective, basically, we do not know clear-cut answers to this because none of the trials show it. However, in the Acuity and the Horizon trial, it showed that if your platelet count was above 35,000 or 30,000, using dual antiplatelet was relatively safe. So count above 30,000 was not against the use of DAPT in acute coronary syndrome, at least in the acute phase. So in our patient, what happened, they showed a clear-cut, just a thrombus inside the stent. There was no coronary artery restenosis. It was just a thrombotic occlusion of the stent. We got away with basically doing a thrombosuction and putting him on DAPT. So the history is that if your platelet count is above 30,000, DAPT in ACS is actually not contraindicated. We can think of way to minimize the duration of the DAPT, but it's not contraindicated. But in ACS, the first question we ask ourselves, can we actually defer the therapy at all, interventional therapy at all, so that our requirement for a DAPT in thrombocytopenia will be less? And the extensive tool which we use is the FFR. So see this lesion, this apparently shows that it's a fairly tight stenosis. But if we do an FFR, the FFR is normal, which is the fractional reserve. You need not interfere. There are a host of studies which have shown that if your FFR or the physiology of the stenosis is negative, there is no advantage of intervention. So that is why if you have a thrombocytopenic patient, you get a lesion like that which you saw, do an FFR, can I get away without? Can I get away without treating it interventionally, where my requirement for thrombotics will be high? So this is the FFR subset, which shows that it should be good. But should we have to intervene, like the patient which we had, it's an acute anterior MI, ST elevation, he's going to die if you don't open up the artery. Access site decision, I think radial is clearly the choice, because we now know radial, the bleeding risk are far, far less. So basically, what would be our strategy in an ACS? Use the radial artery if we have to intervene. Do we prophylactically do platelet transfusion? The hematological recommendation is not unless the patient is below 20,000, or there is active bleeding, or there is active sepsis with some solid organ malignancy. Basically, the recurrent, so you do not do antiplatelet platelet transfusion if it is more than 20,000, or there is evidence of active bleeding. Your heparin doses should be low, because that is another cornerstone of treatment, is heparin. So you should actually have a lower heparin, usually 30 to 50 IU per kg instead of usually 70 to 100. Aspirin is not contraindicated if your platelet count is 10,000, just only aspirin. Dual antiplatelet can be considered if your platelet count is above 30,000. 2B3A, ticagrelor, pasigrel is better to avoid unless your counts are high. So dual antiplatelet means clopidogrel and aspirin. So if your count is above 30,000, and you have an ACS, and you have a patient like that, it is probably wise to start dual antiplatelet with clopidogrel. Stenting procedure, we can expand the stent. We will not go into the details of it. Now, this is a place where we are going to come in more and more. You have cancer patients surviving longer, and they come to you with an ACS. What do you do with them? So I think the strategy is very simple. For cancer patient with an acceptable prognosis, you treat them like you would do anyone else. So, but with less than 1 year survival, that is where you need to rationalize. So if it is a very high risk ACS, like this person with the multiple myeloma with a totally occluded, he's going to die in front of you, go for an interventional treatment. But if, on the other hand, the ACS risk is not so high, try to manage it medically, and this should be the approach for any patient whose survival is expected to be less than 1 year. So if you have to do it, balloon angioplasty, if the platelet is count, do not put in a stent if the platelet count is basically too low. Basically, the other thing is, if it is greater than 30,000, you can just put in a bare metal stent and do dual antiplatelet. These are for people who will probably require a surgery in the next 4 weeks, or in the 4 weeks period, because with a bare metal stent, you will be able to withdraw the dual antiplatelet within a month. That is the recommendation. On the other hand, the drug-eluting stent will require a more thrombogenic, so you will require a higher state. So if someone has basically is going to have a cancer treatment with chemotherapy or surgery within 4 weeks, you rather do a BMS. If, on the other hand, that is not the case and your count is above 30,000, go for a DES, because long-term prognosis will be better, and you can stop the dual antiplatelet in 3 to 6 months, especially if you're using the newer non-thrombogenic stents. So this is my final slide. So basically, ACS, platelet count less than 100,000. No active bleeding or sepsis. Obviously, if this is there, then you need to be. You risk score. If it is a low risk, do a medical management. Do not use dual antiplatelet if aspirin can be given only if 10,000 and above. But if it's not above 30,000, you should not go for a dual antiplatelet. So low risk TIMI score for ACS, you would actually go for a medical management. However, in the higher risk group, early invasive therapy should be the problem. Again, if the platelet count is above 10,000, you can use aspirin, dual antiplatelet. If it is 30,000, the choice of BMS and DES, I've told you that if you have an imminent surgery in the next four weeks, then it is better to do a BMS. If that is not the case, use a DAPS. CABG you cannot offer unless the platelet count is 50,000. Thank you very much.
So thank you, Dr. Ghosh, for covering the subject nicely. One or two questions from the floor?
The problem when the patient is having bleeding, you have done the stenting, we put on DPAT. Now the patient started having GI bleed, that is in the small intestine. There's a frequent problem I am facing. So what to do at that time?
Now, basically, we are talking about GI bleeding and without thrombocytopenia. That's a different story altogether.
With minimal thrombocytopenia, say around 80,000.
Basically, unless you find that the risk is tremendous amount of bleeding, you will not stop it within 1 month. Within 1 month, most of the stent thrombosis is not within 10 months.
Can you give silastazole in place of Dizole?
There's no evidence to say that it is better. There's no evidence. In fact, what I would do is to carry on with the aspirin, and if clopidogrel needs to be stopped, number one, ticagrelor and pasugrel is probably a higher bleeding risk, so you need to be off that, convert them to clopidogrel, and actually do a very active GI management.
Sir, regarding antiplatelet, should we continue in the whole process?
Big button.
Regarding antiplatelet, by any form, ecosprin, clopidogrel, ticagrelor, should we continue in the whole phase?
Should you continue lifelong in antiplatelet?
Yes, if you have stented with an acute coronary syndrome, if the patient has generally had an acute coronary syndrome, it is lifelong, at least single antiplatelet, even if you have treated him medically. Okay, so that is there. And if it is dual, but with a stent, then obviously the duration of the dual antiplatelet after 1 year will be balanced by the risk of bleeding versus the risk of stent thrombosis. Okay. So if you have a high bleeding risk, convert it into single after 1 year.
Thank you,
Thank
sir.
you.
Thank you.
Debashis, actually, it is not related to your subject, but it is more or less similar. But what about the preoperative precaution, particularly for the newer anticoagulants, or we are commonly known about our clopidogrel and aspirin. What about the ticagrelor and other anticoagulants? For the suppose dental extraction or minor operation, what should be the precaution to be taken?
Okay. So that's a very good question. Actually, there is a lot of recommendation which I've seen from the dental sites and the ophthalmic site. For cataract option, do not stop. No necessity. It's a avascular field. I think.
Ticagrelor and others.
Ticagrelor. Now again, there is absolutely. They say dual antiplatelet. They have not specified ticagrelor or a because it's an avascular. Dental treatment, if it is basically just a simple pulling out of a tooth, again the recommendation is not stopping antiplatelet. The thing is, how far was the stenting? Say, if it is within 3 months of a stenting procedure and you have to do the surgery, you have to do, say, dental, if you can manage it locally and say, take it beyond 3 months, then it becomes simple. You can convert it to a single antiplatelet with ecosprin, extract the tooth and put it back. Again, the dental says there's no necessity of stopping dual antiplatelet. This is the dentist recommendation from the Association of Dentists in America. Because you can manage it locally. But I would be reasonable about it. If the stenting is more than 3 months old, the chances of stent thrombosis become very less, especially with the modern stents. So you can actually get away with, do not stop everything, but stop at least the clopidogrel or the pasugrel. Keep him just on the ecosprin, switch him over to dual antiplatelet as soon as they receive. But for cataract extraction, there is no recommendation at all.
So if there is no question, thank you, Dr.